Ty? Okay. So it's really a great pleasure to introduce Dr. Shonni Silverberg. Anyone who knows
Similar to raloxifene, they are also not approved for use in primary hyperparathyroidism by the FDA or in Europe either, but they are an off-label option for patients who've had an unsuccessful parathyroidectomy and in whom the reason to consider reoperation is low bone density. And finally, denosumab, more recently studied, is also associated with an improvement in spine and hip bone density, although it too is not approved specifically for use in primary hyperparathyroidism. And I show you this particular figure from one of the several small studies in primary hyperpara patients with osteoporosis, because it actually not only shows that the bone density increases in patients with primary hyperparathyroidism treated with denosumab in the black bars, but it also shows that the improvement in the hyperpara patients was actually better than the improvement seen in a control group of patients with osteoporosis, but without primary hyperparathyroidism, also treated with denosumab. So it works even better in these patients. So it certainly is an option. What if the bones are fine, but the patient's serum calcium is elevated, and what do we have to address that specifically medically? I have this slide here with the X through the phosphate just to remind you that phosphate used to be used, and we still occasionally will see somebody come in from the outside with hypercalcemia whose primary care physician has put them on serum phosphate to lower their calcium levels, and we absolutely do not advocate that in patients with any form of hypercalcemia, and certainly not in patients who've had failed parathyroidectomy because of the potential issues of metastatic calcification or ectopic calcification. And we certainly don't advocate that in people who have had failed parathyroidectomy. On the other hand, calcimimetics are an attractive agent in this regard. This was a slide that came when cinacalcet was actually first came not even to market, but was discovered as a drug, and this was what we thought and hoped that cinacalcet would do. It is a calcimimetic, and it would mimic calcium on the calcium sensing receptor and lead to a decrease in parathyroid hormone secretion from the parathyroid adenoma or from the hyperplastic glands, and as a result, PTH would not be high, and there would not be any of the sequelae that are seen in primary hyperparathyroidism. What we know is that, at least in terms of serum calcium, cinacalcet has fulfilled its promise. And what you see on the left-hand side in the left-hand panel is that serum calcium does normalize, and it actually normalizes no matter where, or you can, not in everybody, but in almost everybody, you can get the calcium levels to normalize if you give them enough cinacalcet, no matter where the starting serum calcium is. You see some as high as one group where it was in the 11 to 12 range, and another group in the mid-10s, and all ended up in the normal range. You can also see that conversely, parathyroid hormone does not normalize, although the levels fall. Actually, what happens in kinetic studies is that the PTH is back up at its baseline before getting the next dose. But still, this is a way clearly that you can lower serum calcium in patients who have failed their parathyroidectomy. On the other hand, we also know that there is virtually no effect of cinacalcet on bone density in primary hyperparathyroidism. So the increase that is seen after parathyroidectomy does not occur with cinacalcet at any site. And so what we now know about cinacalcet is that it is not a medical parathyroidectomy. It does normalize serum calcium, but there is no clinically relevant changes in bone density. The data on stones are limited, but there really is no suggestion that it decreases stone formation. There is no improvement on the SF-36, which is a quality of life vehicle that is very well validated. So there's no sense that the neuropsychological effects associated with primary hyperparathyroidism improve, but it is safe and well tolerated. And so while not recommended in all patients, it is certainly something that can be initiated in patients after a failed parathyroidectomy if the only issue is the elevation in serum calcium. I'd like to turn just briefly to some special circumstances, the first one being normocalcemic primary hyperparathyroidism. Just to review very quickly for this group, in normocalcemic hyperpara, the PTH is always elevated, right? So the calcium is normal. So if the calcium is normal and the PTH is not elevated, you don't have a disease. But so you have an elevated PTH, but the actual calcium, either the albumin-adjusted total calcium or the ionized calcium, is always normal in the course of monitoring. And all knowable causes of secondary hyperparathyroidism have been ruled out. The most common one, of course, is vitamin D deficiency, as we talked about earlier. And that, of course, is the most common explanation for the set of labs that are seen in hyperparathyroid and normocalcemic hyperpara, is the coexistence of hypercalcemic hyperparathyroidism with vitamin D deficiency, which lowers the total calcium into the normal range. And then if you fix the vitamin D deficiency, the patient becomes hypercalcemic and looks for all the world like a routine hyperpara patient. So these are a small group of people. And the fifth international consensus panel really didn't change the guidelines for management because there are no guidelines for management. So basically, everything is by the seat of our pants. We are deciding based on some expert opinion, but even the experts felt that there were no particular guidelines. And so what most of us do in the absence of data is that we follow people carefully with what we think is normocalcemic primary hyperpara. And if they progress over time to become hypercalcemic, we use the same guidelines as we do in asymptomatic hyperpara that we discussed earlier. If they don't develop hypercalcemic hyperpara, then we look for progression of disease in terms of worsening bone density or fractures, the development of kidney stones and nephrocalcinosis. And then we consider surgery. But again, it is important to realize that this is not evidence-based. And I will say that that I have an extremely high threshold for sending people with normocalcemic hyperpara for a first surgery. My threshold for a second surgery is in the stratosphere. Again, talking about the postoperative diagnosis in the patients who have a normocalcemic hyperpara, again, the only way to document cure of normocalcemic hyperpara is that the PTH must normalize. So you can't have a post-op high PTH and say, well, it's still normocalcemic hyperpara and they're cured, until or unless if there is a secondary cause, you can fix that. But ultimately, the PTH has to normalize to document cure. There is, again, no evidence-based guidelines for surgery. The hypercalcemia is not a problem by definition, right? Normocalcemic hyperpara is not hypercalcemic. And if there is osteoporosis in any of those patients, they can be treated medically. So to reiterate, I almost always just treat their osteoporosis and don't send them for another surgical procedure. Parathyroid cancer is clearly a special circumstance because if the picture is suggestive of that, reoperation should always be considered. So as opposed to what I said before, almost never, here, almost literally always. And then the final special circumstance that I'm going to mention is pregnancy. One would hope that this is something that doesn't happen. I mean, we don't see that many people who are that young with primary hyperparathyroidism. But if someone is a young woman of childbearing age who has an unsuccessful parathyroidectomy, they should all be counseled about pregnancy and consider whether or not there's a need for reoperation before they become pregnant. If they do become pregnant after their unsuccessful parathyroidectomy, most of the patients can, as with for the initial an initial diagnosis during pregnancies, most of these people can be followed successfully without parathyroid surgery. If the blood calcium is consistently in the mid-11s or higher, surgery should be considered early in the second trimester. There are, of course, significant limitations on what you can do that are made worse in a reoperative setting. Obviously, you have very significant limitations on preoperative imaging, really just to, for the most part, to ultrasound. And certainly something like cinacalcet is not a great option in somebody who's pregnant, nor are other medications that lower serum calcium. And so this is a difficult situation to encounter. So to summarize all that we've said up to this point, after an unsuccessful parathyroidectomy, I'm sorry, if the PTH is elevated, accurate diagnosis will guide the appropriate management, figuring out what the patient actually has. Reoperation is appropriate in some but not all cases, and the decision about which cases should be considered for reoperation will depend on the severity of the primary hyperparathyroidism and on the likelihood of cure, which will depend on review of the initial surgery and on preoperative localization results after the unsuccessful attempt. Watchful waiting or medical management of some manifestations of primary hyperparathyroidism can be a really successful alternative in these patients. Hypercalcemia, as I said, can be treated with a calcium mimetic. Osteoporosis can be treated with a bunch of different things. And in normocalcemic primary hyperpara, osteoporosis can be treated if it's there, and if it's not, there really isn't any reason to consider reoperation. So with that, I'm going to turn to the cases, and thank you all for your attention up to this point. I realize I can't actually see any of the rest of you. I'm not sure if how I get you guys back. Participants, maybe, is that it? No. Is there anyone?
If you
Towards
stop
the top,
sharing, you should be able to see us.
there should be an option to pick videos.
There should be something that so I should be able to manage the view, right? Under the view, I should be able to full screen for participants. No, that's probably not it. Well, I guess I don't have
think
to.
if there is a spot that says stop sharing,
Yeah, there is, but
then if you click that, then you'll see the participants and we won't see your slides anymore.
yeah, so we
Yeah,
need
You want to see your slides.
yeah, we need to see the slides. So what I'm going to do is I'll just ask for input, and people can jump in even if I can't see you. So here's case number one, and these are just sort of a few cases that are illustrative of what we've been talking about. So here there's a 64-year-old gentleman. He's diagnosed with primary hyperparathyroidism, and he actually has it. His calcium is 10.4 with an upper limit of normal of 10.2. His PTH is 142, and his 25D is 18. He goes for parathyroidectomy, and then he goes to see his surgeon. And his instructions from the surgeon were to take calcium 600 milligrams 4 times a day for a week after surgery. And he comes back for his 3-week postoperative visit to see the surgeon. And at that time, his calcium is 8.9, and his PTH is once again elevated at 112. So the question then is, what is his likely diagnosis at his postoperative visit? Is it A, persistent primary hyperparathyroidism? Is it B, recurrent primary hyperparathyroidism? Is it C, normocalcemic primary hyperparathyroidism? Or is it D, secondary hyperparathyroidism? So if anybody wants to jump in with an answer and an explanation, that would be great.
Is it
How about
D?
fellows? Go ahead.
Is it secondary hyperparathyroidism because of vitamin D deficiency?
So it is, okay, it is definitely secondary hyperparathyroidism, at least partly due to vitamin D deficiency. So that's the correct answer to that question. And now the next question is, what is the best approach to management? Repeat the labs at 3 months post-op to see if the PTH is normalized. B, resume calcium supplementation to 1 gram a day between diet and supplements, and repeat the labs at 3 months to see if the PTH normalizes. C is to treat the vitamin D deficiency and repeat the labs at 3 months to see if the PTH normalizes. Or finally, to treat the vitamin D deficiency and resume calcium supplements to 1 gram per day between diet and supplements, and then repeat the labs at 3 months to see if the PTH normalizes. Any thoughts?
Rhonda, do you want to say what you would do?
I think maybe C, treat vitamin D deficiency and repeat labs at 3 months.
Any other thoughts?
Sure, this is Ty. I think I would make sure he has adequate calcium and D. So answer D and then see where this PTH is going.
Yeah, so that's exactly right. I think the thing is that, the vitamin D deficiency is definitely a problem. And if you just give calcium and you don't give D, the calcium's not going to get into the system. On the other hand, if you just give vitamin D and you don't give calcium, the proximate reason for a secondary hyperparathyroid response in patients who are vitamin D deficient is the little blip downward in calcium, right? So calcium sensing receptors respond not to vitamin D, but they respond to ambient calcium. And so if you do one without the other, your secondary hyperparathyroidism is not going to be corrected. So the correct answer in this person is D. And with a calcium of 8.9 at three weeks postoperatively, we feel pretty confident that this person is cured of the primary hyperpara, and what we're seeing now is a secondary hyperparathyroidism that hopefully will be short-lived. Case 2. In 2011, a lady is diagnosed with hyperpara. She has a 132 milligram right upper parathyroid adenoma removed. Postoperatively, everything is normal. She has a heart attack. She has a low trauma fracture and is treated with Reclast in 2014. And then in 2016, she becomes hypercalcemic. To 10.5, again, has a T-score of minus 2.5. And this is just a set of labs, and we'll discuss them a little bit on the next slide. In 2019, her calcium is normal again, but her PTH is high and her vitamin D is low. She has a 4D CT that shows a borderline enlarged right lower gland. And in 2020, her calcium is back to being 10.5 again. The PTH is minimally elevated. And after her vitamin D repletion, her 25D is beautiful. She has bilateral venous sampling and it's negative, and she has even slightly worse osteoporosis. So the first question is, what was her diagnosis in 2016? Is it persistent or recurrent primary hyperparathyroidism?
Would it be recurrent? Because it's been more than 6 months?
Absolutely. So that is a definitely correct answer. And so I know this sounds silly because we're just talking about, these words and names, but if they're bandied about incorrectly, it can lead to a lot of confusion and incorrect management. So this is the first thing. You're absolutely right. Now, let's talk a little bit more about 2019. What does she have then? You see normal calcium, high PTH, low vitamin D. Does she have persistent primary hyperparathyroidism, recurrent primary hyperparathyroidism, normocalcemic primary hyperparathyroidism, or primary plus secondary hyperparathyroidism? A bit of a mean question, but if you think about the physiology, it's gettable.
Is it D, primary plus secondary?
Give them a gold star. Okay, so absolutely, that's exactly what it is. So you already know that 3 years before, there was a picture of primary hyperparathyroidism. So it doesn't go away magically, and nothing has been done to make it go away. We knew it wasn't persistent to begin with. It was recurrent. It isn't normocalcemic because you cannot make that diagnosis. Never mind, let's say you didn't even have the prior labs. You can't make the diagnosis of normocalcemic primary hyperpara in someone with a vitamin D of 15. You have to fix all secondary causes. And if you did that in this person, she would become hypercalcemic again. So what you have is a further rising of her PTH level due to the secondary hyperparathyroidism caused by her vitamin D deficiency in somebody who has underlying primary hyperpara. And so finally, what options would you consider for her after her 2020 studies? Would you repeat her next CT? Would you do a minimally invasive parathyroidectomy? Would you do a bilateral neck exploration? Or would you undertake a medical approach to her osteoporosis?
Well, I'll take a chance because no one's popping up, but I would definitely treat this patient medically, Shonni. I wouldn't operate on her. Maybe I'm too conservative.
Yeah, well, that's what I would do as well. This is a bit of a trick question because there is only one really wrong answer, and that is to do a minimally invasive parathyroidectomy. If somebody thought for whatever reason that a bilateral that surgery was indicated, a bilateral neck exploration would be the only one that would make sense, because there's no localization. But I wouldn't do that either. I would also like Joe. I would her osteoporosis isn't that terrible, and her hyperpara isn't that terrible. Her calcium is only minimally elevated, the PTH only minimally elevated. She's doing fine. So treat her osteoporosis and call it a day. But one could argue some of the others a little if you were more adventurous. Case number the last. And it's a little after 5. I'm so sorry that this has gone over, but so if anybody has to leave, please feel free. The last case, 60-year-old lady with primary hyperpara, normal vitamin D, not very elevated calcium, and osteoporosis. Sestamibia is positive in the left upper. They do a left-sided minimally invasive, remove a big juicy adenoma, and the intraoperative PTH does not fall by the requisite amount. It falls a little bit, 188 to 133. It is converted to a bilateral operation, and there are the 2 glands on the right are removed. The intraoperative PTH level goes from 242 ultimately down to 85, certainly more than a 50% drop. The operation is terminated, and at the 3-week postoperative visit, the calcium is persistently elevated. And so the question is, what is her diagnosis at her post-op visit? Anybody want to just jump in quickly because I know we're over time?
Persistent.
Yeah.
Persistent
Yeah.
disease.
And just to look at the intraoperative PTH levels, to characterize the response, and again, I'll go through this. I'll do it sort of quickly, just because, again, I'm sorry that we're over time. The options we've given most of them, the left side response is clearly insufficient. Okay, it's not dropping by 50%, so the absolute correct thing was done in terms of converting to bilateral exploration. The right side, the question with the right-sided response is whether it's a sufficient, insufficient, or equivocal. It's not an insufficient response. It does go down by 50%. But in retrospect, it was obviously equivocal because it didn't normalize. And so this is always a question for our surgical colleagues is when to terminate an operation if it doesn't normalize. And there is always at least a small risk that in people who PTH doesn't normalize, that equivocal response may be associated with a situation which does not really document cure. And so in this, I would probably say that D is the best response because the person does have persistent primary hyperparathyroidism. And so with that, I am going to stop sharing and thank you all for your really remarkable attention above and beyond for at least 7 extra minutes. I'm happy to stay if anybody has any questions and wants to ask, but I do understand that people have lives that they need to go back to. And again, I thank you for your attention.
Thank you, Shonni. That was terrific. It was fabulous, and I think people probably do have questions. I have a comment and a question. First of all, I wanted to make sure that the young woman I was talking about wasn't you. I didn't know if I could. It was. I don't know who it was, but anyway. The question is, and I may have asked you this before, the EGFR less than 60 in the guidelines.
Yeah.
Is there ever discussion in the committee about, is that true if you're 85? Because it's everybody 85.
I agree. I totally agree. There were loud fights. I'm surprised you didn't hear them all the way in Milwaukee. I mean, basically what we pointed out was exactly what you pointed out. That means that every octogenarian who is diagnosed with primary hyperparathyroidism meets surgical guidelines, which is really stupid because in fact, in octogenarians and nonagenarians, we don't want to operate unless there's a really good reason to operate. And so what people said was we picked 60 and we included it because there are some data that suggests that not that there is a reversal of low EGFR in patients who have parathyroidectomy, akin to the improvement in bone density that we see after parathyroidectomy. So that doesn't happen, but there are data that suggest that people who have surgery decline less over time after the surgery than people who don't have surgery and who are just observed. But I absolutely agree with you. Implementation of these guidelines is what really matters. And I don't use this in people who are really old. I just don't use that particular guideline. If I have a 70-year-old diabetic who has who has CKD, I would tell them, look, you don't need this extra thing. I can't say with 100% certainty that primary hyperparathyroidism is going to actively worsen your renal function, but you already have one whammy against your kidneys, and this is a potential second. And I can't say that it's not. So, I mean, you can't get rid of the diabetes, but you can get rid of the hyperparathyroidism on Thursday at 4 o'clock. And that's a good thing to do.
Now, I think I saw a hand up. Does somebody have a question?
Yes, this is Denise Joe. Dr. Silverberg, thank you very much for the talk. I have a couple of questions. One is about the effect of phosphorus to try to differentiate primary versus tertiary hyperparathyroidism. Sometimes I see patients that are older and they have CKD and calcium continues creeping up, 11.2, 11.5, 11.8. And sometimes we have to decide if this is primary versus secondary. So in general, I see if a patient has CKD with a GFR that is significantly lower than 40, phosphorus tends to be high, but if a patient has primary hyperparathyroidism, phosphorus tends to be normal or sometimes borderline low normal. Have you noticed that because that's some referrals that we get from nephrologists saying that this patient has primary, not tertiary. So they see patient, somebody says has tertiary, then the patient is sent to endocrine for evaluation of primary hyperparathyroidism.
So I don't care that much, which I think makes people a little crazy. I don't care. I mean, basically, if somebody has, I mean, I think that the phosphorus can certainly be helpful. I'm not trying to be glib. I think, I actually think phosphorus is helpful in all hypercalcemia because I was talking with the fellows earlier about how they were being tortured by non-parathyroid mediated cases of hypercalcemia, and there the phosphorus is really a helpful thing in terms of differentiating. But I don't know that it's going to, the really important question is, how is this going to change your management? And I think that if somebody has a calcium of 11.8, you have to do something, whether it's primary or tertiary. You know, I think that the question used to be a question of, you know, to operate or not to operate. Now that we have cinacalcet, you have another lever to pull, but you're definitely going to want to do something in any case.
Goes to my second question, that some of these patients, I give them cinacalcet and they don't tolerate. They get very nauseous. So calcium still is in the 11.8 range, doesn't go any lower because they don't tolerate it. Some of the patients eventually went for surgery, but have you referred patients for alcohol embolization if they are not surgical candidates?
Yeah. So at our center, everyone is a surgical candidate. There is no such thing as someone who's not a surgical candidate. We have fabulous parathyroid surgeons, and so do you. So I think that there are people who are not surgical candidates somewhere else, but not in Wisconsin and not at Columbia. You know, this is a procedure that can be done under local anesthesia, and it's the anesthesia. I mean, nobody wants to, but if they have to, they can do it under local if that's the thing. And we don't. You have to do what you do well, and at our center, what we do well is parathyroidectomies, even in very, very high risk patients. We realized this because the very first parathyroidectomies under local in the world actually were done at Columbia by Dr. Paul Legerfo, may he rest in peace, who died very, very young. But basically, we had the only heart transplant program in the country initially. And there were a couple of heart transplant patients who had severe primary hyperparathyroidism, and he just operated on them and, you know, in their beds under local anesthesia. And it was that he realized that he was, excuse me, he was operating on the sickest patients under local, and he was doing the people who weren't sick at all under general. And so he started to you know, to do the under local more commonly. So, you know, you do what you do well. If your center does alcohol ablation well, I really don't know a lot of places that do that really well. So I would much rather have these wonderful surgeons have the control that they have when they do an operation than send for alcohol ablation. What you're mentioning about the cinacalcet, by the way, it's a big problem. Cinacalcet is expensive and not well tolerated. And I almost never use it if I don't have really have to.
Thank you.
Are there any other questions? If not, I have kind of a comment question. And I'd love the fact that you came out and actually said that the bar should be higher for most patients who need reoperation, because to me it makes so much sense. But a lot of times there people just say, well, you just apply the same guidelines. But especially if someone's had a good operation by a good surgeon. And the other thing, and I'll ask your opinion about this, I tend to tell the surgeons that I think hypoparathyroidism is a lot worse than mild persistent hyperparathyroidism. And I want to know your opinion.
Totally. There's just no question. I mean, all you have to do to know that that's true is to take care of 2 patients with bad hypoparathyroidism. They feel terrible. They feel terrible a lot of the time. I mean, now a lot of our patients are being treated with PTH and they feel slightly less terrible. But the number of patients with hypopara, not relative hypopara, but real hypopara, who are brittle and who have difficulties and, who have to wake up in the middle of the night to take, I mean, it's a bad disorder from clinical point of view. I'd much rather have people, I basically send almost everybody for surgery. But having said that, if somebody has primary hyperparathyroidism, it's generally not that bad a disease.
So yeah, I think I feel the same. All these large studies with SF36s and the kind of soft data, but if you look at hypopara, you'd probably need about 10 patients
Yeah,
to show SF36 problems, maybe less.
yeah, yeah, for sure.
Any other questions?
I mean, if there is some time, I want to ask one, if that's okay.
No, go ahead. Video.
So, we are seeing a lot of bariatric surgery, post-bariatric surgery, hyperparathyroidism that, in some sense, they do look like that hyperparathyroidism with normal calcemia because their calciums are normal, at least the ones that I'm seeing. Vitamin D, once we correct, and I'm, there's we rule out all the secondary causes, 24-hour urine calcium. So, calcium is not always on the lower end. It is secondary hyperparathyroidism. That's how I label it. But some of them, like really, there is no kind of solution, even if I increase the calcium.
Yeah, if you increased it enough, there would be a solution. So that's the problem, is that after bariatric surgery, we are not reluctant to increase vitamin D, no matter how much we have to do it. So, most patients do okay on, 50,000 twice a month, some 50,000 once a week, some 50,000 twice a week. I have one woman after bariatric surgery who's on 50,000 a day. And we are lucky because, as I alluded to before, with vitamin D, you have the blood level to follow. So you're not going to do anything terrible. If their blood level is low, you give them more, and eventually you'll be able to get where you need to go. Problem with calcium is that the calcium level is okay, right? So we don't actually become, frankly, hypocalcemic, even if the body is saying, please, 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 give me more, give me more. And the way it says give me more is by secreting parathyroid hormone. And so what we do is, as you know, that calcium and vitamin D are absorbed in the same proximal part of the small bowel that is bypassed in a lot of these procedures. And we give, some post-bariatric surgery clinics don't really emphasize calcium. They just emphasize vitamin D because, they know that the level is low. So giving vitamin D without calcium is useless. Giving vitamin D with a regular calcium intake, like 1,200 a day, may just not be sufficient in these people. And people get worried, particularly because a lot of these patients who are morbidly obese also have a lot of cardiovascular risk factors. And their cardiologist goes crazy when you say 1,200 a day is not enough in you. You're requiring, 50,000 of vitamin D every single week, which is, 100 times the RDA or 10 times the RDA or whatever it is. Why wouldn't you also require significantly greater calcium? So I negotiate with the cardiologist. I say, I promise it's going to be okay. We're all going to live. We're all going to survive. We have to make them do repeated 24-hour urines, which the patient hates. But if you are really rigorous about it, you will find that there is a sweet spot that you get to, often with 600 3 or 4 times a day, that will make the parathyroid happy. Now, I don't mind if the parathyroid isn't totally happy, but especially in those people, because their bones tend to be good, even though they lose bone after parathyroid, after bariatric surgery. But it is secondary hyperparathyroidism, and it is absolutely not normal calcemic.
So that's the 24-hour urine calcium, like, that's how many times I should do. So that's what I get into. Like, we get them, sometimes they're okay, sometimes they're low. So is there a level you shoot for, or just going down the PTH is when you know that the calcium is adequate?
So a normal 24-hour urine according to the lab is 100, okay? That's low. So if you have somebody who should be malabsorbing calcium and their 24-hour urine calcium is 100, give them more.
Okay.
Until they get their 24-hour urine calcium into the high 100s or the low 200s. I mean, if the parathyroid hormone normalizes, you don't have to just keep on doing it. But if your PTH is still high and your urine calcium is 125, add another 600 milligrams or give them, get them to eat another meal. That's not such a good idea because all those things are going to be high caloric. But that's really what's going on. This is all a secondary hyperparathyroid process. And we really, in so many ways, have taught people to recognize low vitamin D, but have not been as good as at telling them that the vitamin D only works if enough calcium is coming in.
So would you agree that the diagnosis of normal calcemic primary hyperpara cannot be made in a patient who's had a malabsorptive bariatric procedure?
Anybody who has malabsorption of any kind cannot be diagnosed with normal calcemic primary hyperparathyroidism.
So I did not think that there